So now I have the honor of introducing our next speaker, Dr. Janet Choi, a board-certified otolaryngology head and neck surgeon, say that a couple of times, and a fellowship-trained otologist, neuro-otologist at Keck Medicine of USC, specializes in treating ear-related disorders. Dr. Choi's research interest centers on addressing stigma associated with hearing loss and hearing device use and improving utilization of hearing health care. She earned her medical degree from the Johns Hopkins School of Medicine. Yay. I'm an alum. Completed her residency in otolaryngology, head and neck surgery at University of Southern California, and her fellowship in otology, neurotology, and lateral skull-based surgery at the University of Minnesota. Please welcome Dr. Choi to speak about hearing loss and its impact on cognitive function.
Do we have the clicker any chance or a pointer?
I don't know. I don't think we have a pointer, so you'll have to.
Or mouse works maybe.
Maybe the mouse works.
Yeah. All right. Hi. Yeah. Thanks so much for a great introduction. Nobody really knows what otolaryngologist does. I'm an ear doctor. It's just simply I can say that. So my name is Janet Choi. I'm a faculty with the ENT department, and I specialize in ear-related disorders. My research background is actually mostly on the public health and the epidemiology. I really love the conversation that has been happening this morning. We can sort of step back aside, and then we're going to look at this association with the hearing loss and cognition more on a population level. It's an honor to be able to sort of be in this setting and a very collaborative work. I'm really excited for the rest of the talk today too. So with that, I have no disclosures, unfortunately. For the key objectives today, so I just wanted to go over the current research findings on this association between hearing loss and dementia, and I will also go over some of the potential mechanisms underlying this association. Then I wanted to present the existing data on the effects on the hearing rehabilitation, such as hearing aids and the cochlear implantation on the cognitive function. And then I would like to end with some of the public health implications, actionable items, and the future directions. So the auditory pathway itself is very complex, as you can imagine. It involves a lot of different organs and the structures. For the purpose of this presentation, we can sort of simplify and just think of it as sound entering the ear, and then the input of the sound ascends into the brain. And if you're someone who has normal hearing, it'd be really easy to understand someone just saying this next to you, right? I find myself frequently asking people to repeat themselves. But imagine you're someone who has a significant hearing loss, and this is what it's gonna sound like, because you're gonna miss some of the phrases, some of the words. It's gonna say that I find self, writtenly, peep, read selves. So you can see if you put a lot of close attention with the context, you may be able to kind of figure out what this person is trying to say, but it takes a lot of effort to really truly understand what this person is trying to say. And this is the sort of concept of the listening effort and cognitive load with the hearing loss. And this illustrates sort of like a good point throughout the presentation today. So one of the early discussions that sparked this research area came out in 2011. So it's sort of relatively new research findings. And then in this study, there's looking at the population of older adults in Baltimore longitudinal aging of health. They found that there is an independent association between hearing loss and incident dementia. And then they also found that there was a dose-response relationship. So those people who have more severe levels of hearing loss were more likely to have higher likelihood of dementia in the later life. And since then, there has been numerous studies. I'm sure all of you probably saw studies coming out, hearing loss and dementia. So people, probably some of the patients, a lot of my patients actually come up to me, do I need to do something because I have hearing loss because I don't want dementia? So far, just based on the evidence, this is something that I would comfortably say, that dementia is more common among people with untreated hearing loss, and then people with untreated hearing loss tend to perform worse on the cognitive test. And then people with untreated hearing loss tend to develop cognitive decline earlier than the peers with normal hearing. So this is just based on summarizing what we know so far. So this is a systematic review that was published in 2018. All of you probably know this various cognitive outcomes better than me, and this is just to summarize that the researchers found that there is an association with the hearing loss and cognitive outcomes across all different sorts of domain. You can see for attention here, I don't know if you can see my clicker, but attention, delay recall, fluency, global cognition, and the list goes on and on. And then they found this for both cross-sectional studies and also for the longitudinal cohort studies as well here. And then they also looked at more clinically relevant outcomes, defining cognitive impairment based on the cutoff scores, right? And then they also looked at the clinical diagnosis of dementia. And as you can see, overall, there is a significant association between hearing loss and cognitive outcomes. And this is another study, sort of the major study that came out in 2020. Maybe some of you are already familiar with it. This is the Lanchin Commission group, and they looked at 12 different potentially modifiable risk factors for dementia, including hearing loss. And then in their pooled analysis, they calculated something called a population attributable fraction, meaning that this is a proportion of a disease incidence in a population due to a specific exposure. And then in this analysis, they found that the hearing loss in midlife contributes to 8% of development of dementia in later life. And surprisingly, this was higher than some of these other known risk factors that includes less education, traumatic brain injury, hypertension, alcohol, obesity, smoking, and a lot of these medical comorbidities too. And for the caveat, obviously they were assuming 100% causal relationship between hearing loss and cognition, which is most likely not true. And then in this analysis itself, they weren't really looking into the additive or synergistic effect with the multiple risk factors. But still, it was sort of interesting thinking that in this analysis, if we can eliminate hearing loss per se, that we can prevent 8% of the dementia. So that's actually a pretty striking number. But the question still remains, right? Is hearing loss still just a mere indicator of early dementia from common pathology that's shared between these two diseases, right? Or is there really a causal relationship? And if there is a causal relationship, can we actually modify the risk by treating the hearing loss? So these are sort of the main questions in this field still. So this is sort of summary of the literature so far. So hearing loss is a possible biomarker and a potentially modified risk factor for cognitive decline, cognitive impairment, and dementia. And then there needs to be additional research and randomized controlled trials to examine the role of hearing loss treatment and also understanding these causal mechanisms. So I can introduce some of the underlying mechanisms hypothesis. So one could easily say, yeah, there's probably a non-causal mechanisms. They share a lot of systemic vascular disease or genetics predisposing to both diseases, right? And if this association is completely attributable to non-causal mechanisms, then just treating hearing loss is not going to do anything, right? But there are also a lot of hypotheses along the line of causal associations right now. And then I sort of just largely categorize into three entities, and then we can go over each one by one. So the first hypothesis, more so on the sensory deprivation hypothesis. So in this hypothesis, just having this prolonged sensory deprivation, just not being able to hear, not having this auditory input from hearing loss, actually may have an effect on the brain structures. And some of the evidence that support this hypothesis is that people found that the hearing loss is associated with reduced gray matter density, reductions in the temporal lobe volume, and then the brain regions that notably affected are pertinent for semantic memory. And then the reduced white matter microstructure integrity in cortical regions were crucial for cognitive processing too. And in this hypothesis, some of these other sort of interesting questions will be then what does the duration of the sensory deprivation matter? Like if the person was having hearing loss for 1 year versus 10 years for 20 years, when do we really need to intervene, right? Is there a critical age for intervention? So that's still sort of big questions in our field right now. And then the next set of hypothesis is on information degradation hypothesis. Somebody called this the cognitive load. So imagine just kind of looking back, remember how much the person with the significant hearing loss takes a lot of effort to be able to understand this person is trying to say, right? And in this hypothesis, there are also some of these supporting evidence. One study found that the additional processing required to compensate for degraded auditory perception draws on the same resources needed for other higher level cognitive processing and semantic coding. And then another study also found that the increased cognitive demands required to appropriately encode auditory stimuli requires extensive listening efforts and also draws from the memory, attention, and executive function. And there's another study sort of hypothesized that having this increased cognitive load all day due to hearing loss, and then the ability to compensate for this cognitive changes decline over time, resulting in the earlier presentation of clinical symptoms in dementia. And then last hypothesis I can introduce is the mediation pathway through social isolation. So a lot of psychosocial measures have been introduced, such as loneliness, social isolation, and depression. And there's also a mediation pathway through decreased physical activity and frailty for someone who have hearing loss. Because the association with hearing loss and social withdrawal, isolation, that has been pretty well studied. And then the link between social isolation and dementia also have been very well studied, right? So just kind of thinking that pathway, this is also another one of the popular, well-accepted pathway for this association as well. I'm not going to go too much into detail for this study, but just wanted to point out that in this sort of a large cohort study based on the UK adults, they did see that there was multiple pathways that was significant, independently significant for the association with hearing loss and cognition. There was this direct pathway that was significant, but there was also separate pathway through the social isolation and also through the depression and also moderation through the hearing aid use too. And for the next set of slides, I can sort of switch the gear. I wanted to show you what the current state of hearing health is right now. This schematic sort of summarizes what's going on pretty well. For US adults, 1 in 6 people experience hearing loss, and about 80% do nothing about it. And then on the right side, this is the US adult data. And then you can see that the hearing loss prevalence is very high. It's the blue bars. And then it doubles by aging 10 years. About 2/3 of US adults 70 years and older actually have audiometry measured hearing loss. So hearing loss itself is just very common. But if you look at the hearing aid utilization rate, it sort of lingers around 10 and 20%. And there are a lot of reasons that goes into it. That itself could be a whole 1-hour talk, so I wouldn't go too detailed into it. But this is sort of something to think about, like why is this utilization rate so low, especially for older adults in our population? And because we have come a very long way. The hearing technology has been out there since 1700s. One of the concept is called the ear trumpet, and then I found that in 1700 they made ear trumpet out of buffalo horn. And then they started making it out of metal in around 1800s. And in early 1900s, they came up with the body-worn hearing aid for the first time. And then the picture on the right side, it can actually amplify up to 70 dB. So it's pretty impressive. And since then, the 1990 was the first time when the 100% digital hearing aid came out. And since then, there have been enormous technological advancement. Really, the hearing aids that has been around 20 years is very different from what we have as an option these days. So we have something called a Lyric, which is 100% invisible hearing aid, which also has its own limitations. And I'm sure you've also heard a lot about the over-the-counter hearing aids becoming an option, so it's directly available for the consumers. It has been adapted for hearing aids to be more accessible and affordable for older adults. And hearing aids itself also has evolved as well. So I'll share my experience because I personally have hearing loss just on my left ear. I was born with it, I had surgery. But I didn't really use hearing aids until I was in early 30s. And then I was surprised by all these jewelries that are out there. There are Instagram accounts that are out there. So people try to make it more fashionable. And I really believe that one day, people are going to start wearing fake hearing aids, just like people wearing eyeglasses, right? It really can be a cool thing one day. And then the cochlear implantation, I'm sure a lot of you who especially work with the geriatric population have heard of this. And this really has become a standard of care for people who have moderate to profound hearing loss, who's no longer benefiting from hearing aids. And this is a great technology. So it's a surgical implant, but we can directly stimulate the cochlear nerve and bypassing all the outer hair cell loss. So then kind of sort of natural questions, what happens to this association with the hearing loss and dementia? What if we use hearing aids and cochlear implantation? So this is actually a set of systematic review that came out in 2022. So it has a lot of wealth of information for what has been done so far. And you can see the variability of the findings are pretty high depending on the study, but generally overall, the hearing aid use was associated with a significantly lower risk of cognitive decline, and it was about 19% that they found in this meta-analysis. And they also show that there was a 3% improvement in short-term cognitive test scores after using hearing aids in this population. And this is a study from my research group. I just wanted to introduce this because this caught a lot of national and international attention, which is very exciting. So we were looking at this national population database and wanted to see if there is an association with the hearing aid use and mortality. And in this study, too, we were able to find a dose-response relationship with the hearing loss and the mortality risk itself. So on the top, you can see that's a mortality rate over 20 years of follow-up for people who have normal hearing versus those people who have mild hearing loss, moderate, and severe to profound hearing loss. And then after that, we wanted to look at whether regular hearing aid use, so not those people who tried hearing aids but not using it anymore, because there are a lot of them, unfortunately. But we really wanted to look at people who report using hearing aids regularly. And in this group that we did find that there was a 24% mortality risk reduction compared to those people who never used hearing aids before. And this was adjusting for severity of hearing loss, age, insurance status, socioeconomic status, and other medical comorbidities too. And again, observation studies are still limited because the hearing aid users and non-hearing aid users they're two completely different people. So, hearing aid users are more likely to be older, they have higher degree of hearing loss, but at the same time, they're generally healthier, and you could argue that they do have cognitive ability to actually able to use hearing aids, and that they're probably more likely to be health conscious and then follow medical directions compared to those people who doesn't want to use hearing aids, right? So there are several ongoing randomized control trials right now. This is one of the biggest study. They published a 3-year follow-up results last year. And what was interesting in this was that in their primary analysis, they were including about 900 older adults, and then on the total cohort analysis, they didn't see any reduction in 3-year cognitive decline with the hearing aid use compared to the control who didn't use hearing aids. But they did a subgroup analysis, so they have 2 sort of different cohorts. One was recruited from the ERIC study, so they have, those are for the cardiovascular disease, so these group tend to be older, they have more medical comorbidities, and in this particular group, they did see that there was a 48% reduction in risk of cognitive decline for hearing aid users compared to non-hearing aid users. So that was pretty significant. And again, this was a 3-year follow-up study, so I mean, how long does it take for you to get the full impact of hearing loss? So those sort of kind of remains as a question. Okay, so yeah, so there's still some questions remain. So does that mean that there's a differential impact of hearing loss and cognitive decline? Do we really need to target providing hearing aids for people who have higher risk for dementia, right? So that's still a question. And can hearing aids or cochlear implants can really be an option as a prevention and intervention for dementia? So the main question is, can treating hearing loss would actually prevent dementia? So we still don't know that yet. Can treating hearing loss for people who already have cognitive impairment or dementia, can we slow their dementia progression? So that's another question too. So I didn't want to leave you with all of these questions, so I wanted to give you some answers. So what can you do if you see someone who have hearing difficulties? It's very straightforward. Just offer them diagnostic hearing test. That doesn't cost money, and they should have insurance, hopefully, that would cover the diagnostic hearing test. And just knowing the type and severity of your own hearing loss, I think it's very empowering, and then it's very important. And you can actually monitor your own hearing loss over time as well. And then if the patient happened to be someone who report that they have communication difficulties and are indicated for hearing aids, I always encourage them to at least do a hearing aid trial, because all states have a free hearing aid trial for 4 to 6 weeks. So when they do the trial, I tell them use it for all waking hours for 1 month, and then see if you benefit from it or not. And if you still don't, if you still have some sort of difficulties with it, you can always get a full refund. And what about for patients with dementia? So we don't really have guidelines for treating hearing loss for people who have cognitive impairment, right? The studies have shown that it definitely helps for the communication and their quality of life. But as you can imagine, the prescription hearing aids are costly. They cost about, like $2,000 to $4,000 per pair. And it's really hard to, especially older adults who have dexterity issues, it's really hard for them to manipulate it, especially if they have cognitive impairment on top of it, right? There's some options that has been explored. It's called the personal sound amplification products. So they're cheaper, usually sort of. I like the pocket talker option. It's very simple to use. It's power on and off, and it has volume, and then the person can basically sort of adjust the volume themselves, and that's just $140 on Amazon. So that is a great option, and it has been used in inpatient settings and also in the nursing home settings. I would like to end this talk with 2 quotes for people who have hearing loss for their lives. Marlee Matlin, she's an Oscar-winning actress for Children of a Lesser God, but she was also featured in a recent movie called Coda. I don't know if any of you have seen this. It's a great movie. If you haven't, I highly recommend it. But she said the handicap of deafness is not in the ear, it is in the mind. And Helen Keller also once said, blindness separates people from things, but deafness separates people from people. And really, to the core of our collaborative work, I think we all just share a very simple goal. We just really want to reconnect people who have dementia and hearing loss to their loved ones and the world around them, right? So we just have to listen closely to the science, but also the stories of our patients. All right, so that's it for my talk. And then, yeah, that's my email. So, and then I'm happy to answer any questions right now.
Hello. Hi, thank you so much. My name is Heather Shikadans. I'm a geriatrician and family physician at Harbor UCLA. I just had a question about the idea of some, regaining of function when somebody is actually using a hearing aid appropriately, and how might that impact the way that we do screening for dementia or cognitive impairment in primary care. In our clinic, we have pocket talkers. I'm really grateful for that, so we can use them during the exam or during the screening for dementia. But I'm not sure if the patient has had enough opportunity to sort of like regain whatever reversible cognitive impairment they might have had before they just slap on a pocket talker. So if you could comment on that, that's my question.
Right.
Thank you.
No, that's a really excellent question. And it's something that comes up all the time, because in the studies too, when we restore the hearing, when we look at this, people who are not performing well on the cognitive test, the question is really the cognition, or is it just they're unable to hear? They're just unable to follow directions. That actually impacts the cognitive scores too. So a lot of these sort of randomized controlled trials really looking at the impact on cognition, they look at a specific set of cognitive tests that does not require listening or not a complicated following the directions. But you have a good point. I'm glad that you actually have a pocket talker in your practice, so it actually does not impact. That's one thing that would not bring their cognitive scores down. But it's really difficult to tell. I think it's one thing we could do, at least by just offering a pocket talker to be available. In an ideal world, we would want them to use hearing aids, right? It's a little difficult if they already have sort of advanced cognitive impairment, but especially if you're more screening for someone who has mild cognitive impairment, you just wish if they had hearing loss, you wish they were using hearing aids for, like a couple of years before they came in to do the test, right? Yeah, so I think we, as a whole, feel that we can really sort of gear towards making hearing aid use more available for the people who have hearing loss. But yeah, thanks for the great question.
John Danner at Keck School of Medicine Memory and Aging Center. And I'd like you to comment briefly on COVID, mask use, and lip reading.
Oh yeah, I mean, we get that all the time, especially so someone comes in for the cochlear implant candidates evaluation, so you know that they have bilateral hearing loss, and with the mask during the COVID, that you're not going to be able to communicate with that person. There are a lot of transcription apps that works really well. I'm sure some of your geriatricians may already using this. I use a lot of just typing on the notepad as I'm talking to the patients, which is not ideal. A couple of things that actually came up during COVID was that, I think I definitely saw more people coming in saying that, I didn't know that how much I was relying on the lip reading. All of a sudden I can hear. It was almost, they say it was a sudden hearing loss, which it wasn't, right? It would just happen because people were all covering their mask. But I also see another aspect that their patients come in and just say, I don't want to wear hearing aids because there are too many things I had to wear now. I have to wear glasses, I have to wear masks, and I need to wear hearing aids on top of it. Like, I don't want to do this. I lose my hearing aids all the time. So I've seen that happening for both sides during the COVID. I definitely got more patients coming in saying that I have hearing difficulties, but I also have patients told me I don't want a hearing aid. I don't want to wear hearing aids because I have to wear masks. Yeah. Any other questions?
So I have a question. Hi, I'm Linda. I'm a social worker. I haven't been in grad school in a while, so forgive me. When you're using the word association, is that to mean correlation? Okay.
Yeah, exactly.
Thank you.
Yeah, no, I mean, these are sort of words that we throw out, but I think kind of the main thing is that there is a correlation, but the causation has not been proven yet. So that's something, that was sort of the main point of all of those 30 slides.
I just wanted to understanding. Thank you.
Right. Okay.